Hello everyone, my name is Dulian Machado, a psychology major wrapping up my junior year. I'm grateful you're here with me for this video. Georgia's case makes me wonder, is she simply aging or could this be an early sign of neurological change? I chose this scenario because it really hits home. My grandmother went through something similar a few years back, so I can connect with it on a personal level. Do not worry, I will remain objective. Over the next few minutes, I will summarize her situation and symptoms, walk you through a differential diagnosis, and recommend practical treatments. I also plan to provide an assessment and end with a quick note on ethics and follow up. My diagnosis, treatment, and assessments are grounded in the DSM 5 framework with insights from the 15th edition of Kring and Johnson's Abnormal Psychology, the Science and Treatment of Psychological Disorders. Let us get into it. I will start by diving deeper into Georgia's situation. These details really help paint a fuller picture. For the past 2 years, at the independent living community, she has been capable of handling things on her own pretty well. That said, the staff has started noticing some concerning patterns lately. The staff noted that she had been skipping her noon meal, enough for them to notice. There was also the incident where she left her window wide open during a winter storm, a potential safety risk. Her family lives just an hour away and makes a point to visit most weekends. This provides crucial emotional family support. But last time her family visited, the patient got confused and called her grandson Dylan by his father's name Jose. A single instance of name confusion can often be attributed to normal aging lapse. When this occurs, on top of the missed meals and leaving the window open during a winter storm, it raises concern. This pattern may show emerging deficits in memory and executive processes. The skills for planning, organizing, and sticking to everyday routine. As I examined the case, I could not help but reflect on how this subtle shift can appear gradually over time, particularly in later years, often blending right into what we dismiss as normal aging. According to the DSM-5, the American Psychiatric Association's primary diagnostic guide, these patterns fall under the category of neurocognitive disorder. In Georgia's case, the symptoms most closely align with what is called as mild neurocognitive disorder, NCD. This distinction matters because it helps frame both the diagnostic process and the right interventions. To break it down, the criteria for mild neurocognitive disorder requires clear signs of a modest drop in cognitive performance from her baseline in areas like executive function, memory, or attention, evidenced through concerns from staff, family, or even clinical observations, and ideally supported by formal testing. Diving deeper into Georgia's symptoms, the name makes up with her grounds screams a potential hit to the learning and memory domain. It is one of those classic red flags that pops up in early cognitive shifts. Then there are the skip meals, which may signal executive function challenges, such as difficulty planning daily tasks, and the open window incident might reflect a lapse in attention, where spatial awareness starts to falter. Taken together, these small slips suggest emergency cognitive changes that call for a closer look. Georgia's ongoing independence suggests a mild neurocognitive disorder per the DSM-5. She has had slips in attention, memory, or executive function, but not enough to hinder basic self-care. Still, I confirmed this only after thorough differential exam. A stray name mix-up might be normal aging, yet persistent lapses hint at more. I will start by checking for any underlying factors that could be masquerading as cognitive issues like depression or stress that are messing with sleep, side effects from medication, low B12 levels, or even simple dehydration. This kind of things often mimic real decline but can turn around pretty quickly. Once you address them properly, it's clear that mild NCD fits the best. The 15th edition 2021 of Kring's and Johnson's Abnormal Psychology, The Science and Treatment of Psychological Disorder, provides a clear evidence-based biopsychological disorders. It talks about NCDs, how it involves actual brain changes like plaque buildup in Alzheimer's cases. The text highlights factors such as cardiovascular health and even lifestyle habits like diet and exercise. For Georgia, her blood pressure meds suggest that we should screen for vascular contributions. I remember reading in the chapter on aging and psychopathology how subtle these early signs can be, and how ignoring them can lead to faster progression. And early detection through cognitive assessments can make an enormous difference. So, what do we do about it? Treatment and recommendations should be holistic, as both the DSM-5 and the abnormal psychology text suggest. As your provider, I would like to do a full neuropsychological battery to quantify the deficits. I will start with an MRI to check for brain changes. I'm going to order blood work to rule out the things like B12 deficiency. Socially, to boost their engagement, I'm encouraging more family visits to combat isolation, which can worsen cognitive decline. Diet-wise, I'm aiming for anti-inflammatory foods. I'm suggesting the Mediterranean diet outlined in the book for its anti-inflammatory effects. In wrapping this up, Georgia's story reminds me why I got into psychology. For me, it is about helping people keep their dignity as they age. Initial action here could preserve her quality of life for years. If you're dealing with something similar in your family, do not hesitate to seek professional advice. Thank you so much for staying until the end. I hope this was insightful. Have a beautiful day.